Hi all, my name is Gregory Hugenholtz and welcome to this webinar. I'm a researcher and a doctor attached to the University Medical Center in Groningen in the Netherlands. And today I'll be presenting my research conducted at the Surgical Research Laboratory in partnership with the Academic Medical Center in Amsterdam. And the research is titled TAFI Deficiency Promotes Liver Damage in Murine Models of Liver Failure through defective downregulation of hepatic inflammation. This research is part of a wider range of studies that me and my colleagues have been conducting about the role of various hemostatic components in the progression of acute and chronic liver failure. So this particular research was part of my PhD studies and a chapter in my PhD thesis. And it was also published in the Journal of Thrombosis and Haemostasis. So if you want to have more details about this study, I've attached a QR code below that you can scan. So let me first introduce you to our model patient, which is Mr. Blood. Well, I'll call him Mr. Blood. And Mr. Blood is just like any one of us, but Mr. Blood has cirrhosis. So he is at the end stage of his liver disease. So his liver isn't able to produce coagulation factors as well anymore. So the liver does a lot of things. Among them is the production of hemostatic factors, which control the normal clotting of your blood. So imagine you have a wound, you need a clot to close the puncture. The hemostatic system will then activate and in a controlled way produce a clot that will then stop the bleeding. But you can imagine if you make too much procoagulant or prohemostatic factors, then there's a risk of thrombosis. But if you make too less of them, you might have a risk of bleeding, or you make too much anti-hemostatic components, you may have a risk of bleeding. So usually there's a fine balance. And we know that in liver disease, the balance, and this is backed up by multiple studies, the balance is still there. But because of the reduced synthetic capacity, there are just less factors, so the balance is overall less stable. So something like an infection or something like transfusion or something like a change in acidity in the blood can all tilt the balance in these patients towards a thrombotic tendency or on the opposite towards a bleeding tendency. Now hold on to that thought that there will be a subset of patients with a thrombotic tendency because of their liver failure who developed thrombi into their body because of the liver failure. And now take this further and imagine that those clots are deposited within the liver itself, and that in turn leads to more damage and therefore to more progression of liver disease. And this is exactly what Ian Wanless and his colleagues were able to demonstrate by reporting the presence of thrombi within small and medium-sized branches of the hepatic and portal veins, and they were able to associate them with fibrosis and cirrhosis, which is the end stage of liver failure, and where there's extensive remodeling of the tissue and also a lot of pressure on the veins itself, leading to hypertension in the portal system, which is the system of veins which bring blood or nutrient-rich bloods from the digestive system into the liver. So there are also epidemiological studies backing up this concept of hemostasis/thrombosis driving liver disease progression, and a few of them are exemplified here. For example, this is a study from Wright, which showed that patients who have a thrombotic tendency because of a mutation in the factor 5, which is called a famous mutation, which is called factor 5 Leiden, that these patients, when they contract the hepatitis C virus and therefore develop liver disease and some of them ultimately cirrhosis, that their disease progression is faster than the general population. And there are other examples of congenital mutations in various hemostatic factors that back this up. So let's now focus back to the topic of this presentation, which is about TAFI. And TAFI is just another hemostatic component produced by the liver. And levels of TAFI are decreased in liver failure as a result of this. So TAFI stands for thrombin activatable fibrinolysis inhibitor. So it's activated by thrombin, and thrombin is the end stage of the coagulation cascade. And when it's activated, it reduces clot breakdown. So TAFI has antifibrinolytic properties, but this is also a very interesting molecule as that it has also anti-inflammatory function. So low levels potentially then mean that it could lead to a pro-fibrinolytic phenotype and at the same time lead to a pro-inflammatory phenotype. So why focusing on TAFI in particular is because we know that patients who have very low levels of TAFI also have a very low survival probability, so a high risk of dying, and compared to patients with higher levels. So there's something protective about TAFI, and if we're able to know how these low levels of TAFI, or how the effect of low levels TAFI drive disease progression, then we can do something about it. So what is our hypothesis here? It could be that low levels of TAFI are just a marker of a severely reduced function of the liver, so we shouldn't think too much about it. It could be that TAFI, low levels TAFI lead to a pro-fibrinolytic state, and this affects the liver in one way or the other. You would expect there to be protection because clots would be broken down more easily, so more oxygen and nutrients to the liver. It could also be that there is a more pronounced effect of the pro-inflammatory side, which is associated with low levels of TAFI, and that this drives the disease progression and a worse outcome. And the aim of this particular study was to investigate the effect of TAFI deficiency on chronic liver failure, which is cirrhosis, and also on acute liver failure, which ultimately also leads to decreased hepatic function, but this just goes much quicker. And to achieve this, we set up an experiment where we compared TAFI knockout mice, so mice completely lacking TAFI, and we compared them to wild-type mice. And in the case of chronic liver failure, we used a model where we induced cirrhosis by repetitively injections of carbon tetrachloride, which is an hepatotoxic agent. And to follow up with the course of liver failure progression, we collected livers at the beginning and after 1, 3, and 6 weeks. And obviously we collected plasma to investigate for various changes in inflammation, but also in change in hemostatic components. So for those who are not familiar with the different stages of chronic liver failure progression. I've put them here in a row. On your left side, there's a normal tissue of the liver where you see a lot of nice and healthy cells. Here in the middle, you see a portal vein. Then the second stage, which is response to the hepatic toxic agent. In this case, we use CCl4, but there might be others. For example, alcohol or fatty diets might be other agents. The second stage would be inflammation, where obviously a lot of inflammatory cells go into the tissue, and that ultimately can lead to cells dying, and they are being cleaned up. These patches of cells which are cleaned up are replaced by scar tissue. If there isn't a lot of scar tissue and there's still ample of healthy cells, we'll call this stage fibrosis. But ultimately, if this inflammatory process continues, there might be such an extent of loss of cells that the function of the liver becomes hampered. Not only because there are not enough hepatocytes anymore, but also because the scarring puts so much pressure on the tissue, for example, on the blood vessels, that there might be other changes such as hypertension of the portal system. So one of the first things we've looked at is damage to the liver, and you can measure this by measuring markers of liver damage in the blood. This is called ALT, and the higher the ALT, the more damage there is. Your week 0, this is where both groups starts. The white group is the wild type mice group, which don't have any changes to, obviously they don't have the TAFI knocked out, and then the blue ones are your TAFI knockout mice lacking TAFI. And so in the first week, nothing much has changed. Both groups have the equal amount of damage, but there's a clear difference in the TAFI knockout mice group after 3 weeks. But although there's more damage in week 6, you see that this levels out between the groups. Then looking at fibrosis, again, we start at the same baseline level between both groups of mice, and there's clearly the TAFI knockout mice group takes off here, with much more fibrosis between the first and the third week, and this continues up until the 6th week. So we also looked at inflammation secondary to liver damage, and in this case we used influx of neutrophils as a marker of inflammation. In the old days we would have measured each neutrophil and divide that by the total amount of cells within a particular section, a random section. This was very labor intensive, and in this study this was made much easier by using HistoQuest software. This enabled digital recognition of single neutrophil cells in the mid of the total cell population, as you can see here marked by green lines. And by making use of an ingenious gating method, this neutrophil population could be separated from the total cell population. So here again is your baseline. No difference between wild type mice and TAFI in terms of neutrophil influx at week 0. And then there's obviously an increase as more damage occurs, there's more inflammation. Not too much of a difference in the first 1 and 3 weeks, but at 6 weeks there's a markedly more inflammation in terms of neutrophil influx in the TAFI population compared to the wild-type mice. So we were then eager to find out if we could reproduce these results in the context of acute liver failure. So again, we compared our TAFI knockout mice with wild-type animals, and we used a model of acute liver failure where we injected them with acetaminophen, which is paracetamol basically, in their belly. And again, we collected plasma and livers at different time points after injection to follow up with the course of liver failure progression. So again, for those who are not familiar with acute liver failure progression, there might be different causes of acute liver failure. In the Western world, the most common would be an overdose of paracetamol, or Tylenol, it's called in the USA. There are other causes. For example, it could be that people have eaten the amanita mushroom. Is not a known one. It's a terrible disease. People become really unwell really rapidly. There's a massive amount of inflammation, as you can see here, quite quickly. And where in cirrhosis you would first see fibrosis, and then that leads to more cirrhosis, so remodeling of the organ. In acute liver failure, it's full-on necrosis of the tissue, so basically dying off of the liver. So again, comparable to the chronic failure experiment, we first looked at the amount of damage and the difference between both groups as measured by the amount of AST, which is a marker of liver damage in the blood. Unexpectedly at baseline, no difference between the groups, and slowly you could see that there's a difference between both groups, but interestingly, looks like the wild-type mice have more damage here than the TAFI knockouts in this model. So it looks like initially those are protected after 6 hours of the injection, but at 24 hours that has completely changed and reversed, and here the TAFI knockout mice definitely show more damage in the liver. In this model, we looked at fibrin, which is the protein that makes up clots, and the reason for this is that we want to know what was happening at 6 o'clock. If you remember the slides before this one, mice in the TAFI group were protected, so maybe there was a profibrinolytic effect of the TAFI, which removed clots and therefore protected the liver from more damage. So if you look at here, at 0 hours there's no difference between the groups, at 2 hours also no difference, but indeed you can see that there's less fibrin deposition in the TAFI knockout mouse compared to the wild type. And at 24 hours there's no difference anymore between the groups. Finally, we looked at necrosis in acute liver failure, which is a hallmark of advanced disease. No difference at baseline, no difference at 2 o'clock between the groups. And then at 6 o'clock, also no difference, but you can see that slightly, some mice look more or less protected, but some of the other ones are kicking off here and getting quite a large amount of necrosis, but ultimately no difference statistically then between the groups. But at 24 hours is definitely the TAFI knockout mice get the overhand and lose large part of their livers because of a lack of TAFI. So in conclusion, I introduce you to a new concept that liver failure leads to changes in hemostatic components, and in turn that these changes lead to progression of liver failure. Specifically, we looked at low levels of TAFI, which was shown to lead to a poor outcome in patients with very low levels. We tried to understand that by conducting experiments in mice that were deficient of TAFI and inducing acute liver failure and chronic liver failure in these mice, and we're able to show that TAFI deficiency does increase the amount of liver damage in both models. We're able to show that TAFI deficiency enhances fibrosis and enhances inflammation in chronic liver failure, and that increases necrosis in acute liver failure. We briefly were able to show that TAFI deficiency protects in the first few hours after the injection in these acute liver failure models, but this advantage was lost later on, probably because the inflammation was too much. Taken together, these results suggest a protective effect of TAFI on the progression of liver failure, potentially by virtue of its anti-inflammatory function. And again, I've attached the reference of the paper where this study was published. So coming to an end of this webinar, I hope you have enjoyed it and you now know more about liver disease and how changes in the hemostatic function associated with liver failure can accelerate its progression. The next step will be for us to stop this, potentially by using anti-hemostatic agents, which are safe in these patient groups. And this is one of the topics we're looking at. We're also looking at how we can replace some of these components that are lost, and TAFI would be a candidate for that. We're also looking at how the hemostatic system regenerates the liver. The liver is the only organ which can fully regenerate in the body. I'd like to thank TissueGnostics for giving me the opportunity to post this webinar, and also my colleagues at the University Medical Center Groningen and Professor Joost Meijer for his knockout mice. Thank you very much.